Okay.
So let me remind what we discussed with you in our previous lecture. It was dedicated to general issues of leukemia, including classification, principle, etiology, of course, mechanism of development, principles of diagnosis, clinical manifestation, and main principles of treatment in general. According to Ukrainian standards of education for medical students, and more specifically to students who are studying special and more specifically for students who are studying by the specialty of stomatology, is to be able practically to recognize the morphological type, not morphological, but the type in general of leukemia. At least distinguish acute in general. Even not so obligatory to distinguish acute myeloid, acute lymphoid, at least acute. Chronic myeloid leukemia and chronic lymphoid leukemia. This issue, the ability to distinguish these three groups of leukemias, has a very significant practical application, because in case if you reveal acute form, regardless of its morphological variant, course, etiology, and so on, this person, this patient has, so even just each minute counts, each minute, not even hour, day, or week. So as soon, you should conduct proper treatment for this person, diagnosis and treatment as soon as possible. In case we have chronic myeloid leukemia, it has more significant, more stable changes in the organism, which develop during more prolonged period of time. While we have slightly more time, up to maybe few weeks, few months for our decisions. And of course, in case of chronic lymphoid leukemias, I generalize. There are different forms, but in general, you have much more time, and prognosis is better. And I hope that at the end of this lecture, in our practical classes, we'll discuss peculiarities of stomatological care in these patients as well. So let's proceed. And we continue with acute leukemia. A group of acute leukemias. Of course, we will distinguish them by myeloid and lymphoid types, but what might be even enough for you if you remember some generalized information. So let me remind that acute anemia is a very heterogeneous group, what we understand by heteros. There are multiple different forms of acute myeloid or acute leukemia, characterized by infiltration of blood, bone marrow, and other tissues by neoplastic cells. What is important in this relation? By blasts, non-differentiated blasts. If we have blasts, we have acute. If we have maturing forms of cells, we have chronic. I hope you remember this. And one important thing which remains from general definition of per each 100,000 per year. There are new cases. It is more widely distributed among males than in females, in average, of course. The incidence increases by age. If in patients less than 65 years, it is less than 2 cases per 100,000, while in elderly persons it is much more frequent. It increased over past 10 years by different reasons. It is this rise of incidence of acute leukemia in general and myeloid as well is associated with intensifying of domestic radiation influence in general, especially in due to urbanization in cities. Moreover, with influence of chemicals on the genes because of unfavorable epidemiological and ecological situation and so on. And there is almost no geographic variation by distribution of this disease. On this slide, on this illustration scheme, I'd like to remind you about the principle of diagnosis of acute form of leukemia and acute myeloid as well. So if we are speaking about acute, we are speaking about some blasts, yeah? Non-differentiated blast or partly differentiated blast. Either multipotent or common myeloid or lymphoid. In case you have acute and myeloid, we are speaking about affection of this progenitor cell. Common myeloid progenitor cell. It undergoes mutation, it undergoes tumorous progression, pathological progression, and there could be different results of this. As soon as the half-life period of living of neutrophils is the shortest among different representatives of myeloid lineage, the first histological event in this case will be changes in neutrophil lineage. Risk factors. Acute myeloid leukemia is associated with instability of genome, with genetic hereditary predisposition. In case of Down syndrome, Klinefelter syndrome, so, due to instability of DNA, of genetic structure, genes, chromosomes, there is high risk of mutations, uncompensated mutations. What do you think about going out? What do you think about going out of the room? No, I'm speaking about you. Please don't produce noise, okay? Me? Keep silence. Yes, you person. Thank you. Falconi up. And following changes are associated with hereditary predisposition. Congenital neutropenia, decrease of neutrophils. Fanconi anemia, disturbance of the structure of erythrocytes and therefore decrease of their quantity and concentration of hemoglobin as well. And it's just a misprint, neurofibromatosis, a condition in which have these changes in either nervous system and blood system as well. Radiation and chemicals influence are also associated with mutations, with tumor progression, and the most strict association is stated regarding aromatic hydrocarbons, benzene. Smoking itself, tobacco smoking, is also strictly associated with the danger correspond to benzol-containing substances. Paints also, there are organic solvents which are present inside the paints may also cause this ethylene oxide and pesticides. Such pesticides as chlorine compound, mercury-containing pesticides. Pesticides are poisons that are used in agriculture. Okay, some drugs. Some medications may also have adverse effects or complications with oncological pathology, including leukemia, acute myeloid as well. Activating agents, topoisomerase, second type inhibitors, chloramphenicol, and others. Most of them are related to cytostatins. So in case of cytostatic therapy against some other cancer, some other tumor, they could be complication in the form of leukemia. Then, antecedent for preceding hematological disorders. And the first place in the role of these factors is occupied by myelodysplastic syndrome. As you can see, there is some syndrome, some condition, pathologic state, in which there is problem with production of cells, adverse production of myeloid lineage. Myelodysplastic syndrome. It is stated as it's pathologic condition, of course, but as a pre-leukemic condition with high risk of leukemia development. Aplastic anemia. If you remember in our lectures, practical classes, when we discussed ICO and aplastic anemia, every time we highlighted that in case you would have dysplasia, change of condition of cells, or decrease of their production, there is a risk of malignization, a risk of leukemia development. Myelofibrosis, when we have disturbance in which there is adverse improper growth of connective tissue in bone marrow, myelofibrosis. Because of this, there is disturbance of intercellular relationships and high risk of oncology development. Paroxysmal nocturnal hemoglobinuria is one of conditions in which there is residential of myeloid leukemia development, and polycythemia rubra vera. I was asking some of our classes about the condition in which there is, I remember, in a situation opposite to anemia, when we have much of, or many red blood cells. Here it is, polycythemia rubra vera. It is also a condition associated with the danger of myeloid leukemia development. soon as you, in total of course, are not polite, even basically, and keeping so high noise on my next lectures, I will not let anybody come later than we have to start the lecture. So those who are late will be escaped from the lecture. Okay? So this is last time I let you come in. Next. As a result of these adverse production of adverse forms of blast cells, there is decrease in production of normal blood cells. They are replaced with pathologic foci of hemogenesis. Then, rapid proliferation of tumor cells. What do I understand by rapid proliferation? I remind you, we are speaking about acute myeloid leukemia. This means that the growth, clinically significant growth, takes about few days, weeks, from days to weeks, very quick. In a few weeks, this patient may die without medical aid. Reduction of apoptosis. What is it? Apoptosis. It is a normal cellular death. If you remember from pathophysiology, probably pathologic oncology, normal physiology as well, each cell has a limit of its life. The normal mechanism of cellular death is initiated from inside, from its genotype, genetics, by production of appropriate substances which finally, steadily and gradually kill the cell without any special consequence. During this process, the cell expresses chemokines, substances which lead to coming of macrophages to this dying cell and dissolving of it with macrophage, with monocyte. It's normal. In case of pathologic growth of these cells, this apoptosis mechanism is cancelled, and these abnormal tumor cells start to reproduce themselves, start to live for prolonged time and reproducing themselves. And finally, there is accumulation of these adverse cellular mass in different organs. The most important, vitally important, of course, is accumulation in so-called vital organs: brain, heart, lungs, liver, kidneys, and this may lead to death. This is the reason. The basic diagnostic criteria for acute myeloid leukemia is more than 20% of myeloblasts in blood and or bone marrow. So this threshold of 20% seems to be important to be recognized. Classification of acute myeloid leukemia is very complicated, and I see our teaching staff see no reason to force you to recognize each of these morphological subtypes. This is an international recognized classification, so-called French American region, FAD classification, where we have basically eight forms of acute myeloid leukemia, and this is not flawless. From minimally differentiated leukemia up to megakaryoblast leukemia. So depending on what lineage is affected most of all, what kind of non-differentiated blasts reproduce and represent the main cellular mass of the tumor. These distinguished from each other. As you can see, there is a second chapter, acute myeloid leukemia with multi-lineage dysplasia, where we have simultaneous affection of pancreatitis, for example, and neutrophils as well. And a combination with myelodysplastic syndrome related to the preceding one, acidic therapy. In general, I just want you to understand that there are different approaches to identification of tumorous cells related to acute myeloid leukemia. Cytochemically, immunophenation, when we have special monoclonal antibodies and they specifically bind to the appropriate type of cells and marks that we can recognize this easily by fluorescent microscopy as a variant. Chromosomal evaluation, image of tumor cell, regardless of its origin. I'm sorry, I have to inform you that there are 3 students sitting here, this side, which bother me from lecture to lecture, during this lecture, again and again. They're smiling, they're trying to play some role, but you see, you bother me and neighbors. If I observe that you continue, I will ask you to go out and work on the lecture. I save the right to do this. And molecular evaluation. What do you understand by molecular classification? Each of these tumor cell has a special profile of secreting or excreting substances. And by this we can also distinguish them. Clinical presentation of acute myeloid leukemia. One first, non-specific, but first, by the sequence is anemic syndrome. What kind of anemia is most likely in the case of acute myeloid leukemia? Hypo and aplastic, of course, thank you. The reason is what? Replacement of normal foci of hematopoiesis, erythropoiesis, or there could be specific problem with the primary, with erythropoiesis. Then, infections. It's reasonable. As soon as mostly neutrophile spectrum or lineage is affected, there is problem with what? Non-specific immunity against infections, mostly bacterial infections. But viral infections might also be affected. Then, bleeding. What's the reason for bleeding? Hemorrhagic syndrome. Same. Depression of megakaryocytopoiesis, production of platelets. Thrombocytopenia. In this condition, we have increased risk of bleeding or hemorrhagic syndrome development. Yeah. Anorexia and weight loss, so asthenic syndrome. Yeah, weight loss, physical asthenic, anorexia, psychological disorders. Together with dizziness, everything that we discussed with you regarding any chronic disease. These are non-specific, but very typical first line symptoms in case of acute myeloid leukemia. What are specific changes in clinical manifestation? Of course, infiltration. So, all specific changes in case of any kind of leukemia are connected with metastasis, distribution of the primary tumor in different organs, and formation of extramedullary foci of hematopoiesis. One first clinical presentation of this is connected with splenomegaly. So splena is first. How should I mark like this? First. Then in some time, maybe a few weeks, we observe increase in size of liver as well. Because of the close relationship between blood system and liver. The increase in size of spleen is connected with an attempt of spleen to appear in both of these organs, and this leads to portal and intrahepatic hypertension in liver, and same in the spleen. Hypertension, increasing size, edema, inflammation, and so on. Physically, or by clinical, objective evaluation of this person, we might observe increase of abdomen, in size. By palpation, it becomes painful, and so on. Lymphadenopathy, increase physically, visually. This might be recognized or identified as increased lymph nodes increase in size. At the beginning, they are not they do not undergo any inflammation, so they are not characterized by hyperemia or anything else, just swelling, increase in size, but systemically. That's opposite to what we have in case of lymphomas, but we have more localized forms. So systemic diffuse lymphadenopathy, increase in size of lymph nodes. If there is lymphadenitis developed, in this case, of course, if they become painful, they become to represent some hyperemia about them and so on. Gun hypertrophy. This symptom corresponds to stomatological disorder. If you are not prepared well, or you forgot this material that we discussed with you now, you might suppose that there is just hypertrophic gingivitis and treat it by some usual measures, but these measures will not help if it is caused by leukemia in general, especially acute myeloid leukemia. And unfortunately, at least in our country, we have, I can't say that we have frequent cases of this, but among those people, those patients which develop myeloid leukemia, acute or chronic, unfortunately, one of the first symptoms, one of the first problems that they perceive and which force them to go to doctor is problem with their teeth. Different forms, mostly hypertrophy and bleeding, mostly hemorrhagic syndrome, and painful and some inflammation. They come to stomatologists. If stomatologist is not educated well, he is not ready to recognize these symptoms or identify it with possible blood disturbances, they start to treat it locally. They feel and time is lost, because usually it takes several weeks to treat such condition, and in a few weeks there is no relief, or there is worsening of condition, and additional changes appear, and we lose this time, and it might be too late to start treatment, specific treatment for these conditions. So if you have hypertrophic gingivitis, together with thinking about some infection, about some, I don't know, some other conditions, don't forget about possible blood disturbances. Leukemia acute, so in other words, skin disturbances. Last lecture, I showed you some photographs, pictures of patients with infiltration of their skin with these metastases. They could be small nodular infiltrations or big fields of diffuse infiltration. Infiltration of CNS, central nervous system. It's a very vitally important condition in which primarily these persons represent some non-specific changes like vertigo, dizziness, like often headaches without any help from non-narcotic analgesics. Then some focal changes appear in this slide I try to include respiratory distress syndrome. So accumulation of these cellular mass in different organs affects their function, and these might be clinically reviewed. Some problem with change of slide. Okay. What can we do to diagnose this condition? The basic and most easy way is to administer complete blood count. On complete blood count, the results we observe hypoplastic anemia. What do we mean by hypoplastic? We observe decrease of red blood cells, definitely. More or less intensive decrease of hemoglobin, decrease of reticulocytes, just remind. Normal or decreased color index, and association of this anemia with what? Thrombocytopenia, yes, thrombocytopenia, and changes of white blood cells. And there could be different variants of white blood cells changing. The most common change is of course high white blood cells count. Because basically, laboratorian may not recognize that this increased quantity of white blood cells is explained by accumulation of non-differentiated class, adverse, tumorous cells. Because they look like, but they're similar to lymphocytes, not lymphocytes, they're similar to lymphocytes, but they represent myeloid lineage. But in general, they might be identified as white blood cells. They could be variant when we have more early, when we have normal white blood cells count. This could be two conditions. Either the onset, the very early onset of the disease, when most of changes are localized in the bone marrow. And this is best variant when we have time to start treatment, depress this tumor growth, and succeed with the treatment. Or this one, low white blood cells count, is the most rare and but the most dangerous. If we have not increased but depression of white blood cells production, this might be one of the terminal conditions in acute myeloid leukemia course. As we reviewed before regarding hypoimmune anemia, each case would have symptoms of depression of hematopoiesis with obligatory have to direct expression to hematologist, to therapist at least, and they should administer bone marrow biopsy, aspiration. It's obligatory, second obligatory investigation in this case. And as you remember, we observe 24% of blasts, myeloblasts. This is one of basic signs, symptoms of acute myeloid leukemia, or blast case of chronic myeloid leukemia. And of course, the main aim of this investigation is to identify one of 8, not even 7, but 8, from M0 yes to M7 and 0. Sometimes or cellular chemical types of this leukemia. So once again, greater than 20% of blasts in bone marrow. Here are some accumulation of these blasts. As you can see on this slide, these blasts, why did I say that they might look like lymphocytes? Because they have big nucleus. This is because of their high intensity of metabolism and reproduction of themselves. You can even see one of blast reproduction here, in white. In this case, we have normal bone marrow when we have different classes of cells. How else can we identify these changes? As it was, we said peroxidase. Myeloperoxidase. It is an enzymatic system, enzyme, which production is typical for myeloid lineage in general, and we have increased activity, increased concentration of this enzyme. This is indirect symptom of the intensified proliferation of this metal, this tissue. And evaluation of alpha-lactylbutyrat, esterase, and other enzymatic systems is also associated with myeloid lineage proliferation. And this process of investigation may be automatized by automatic flow cytometry, when equipment automatically dies the specimen with the system vision and just simply print or represent on the screen result of it. And we even make a photo of the cell. Basically, following investigations are required to finally identify the type of acute myeloid leukemia. Cytogenetic studies, race of lactic dehydrogenase level, of uric acid in diarrhea symptom, laboratory symptom, increased prothrombin time, and decreased fibrinogen level, changes in hemostasis system. Then changes in liver and renal function, very often, reduced potassium and calcium and magnesium in some subtypes of acute myeloid leukemia. Fever, in this case, they should be differentiated from fever related to infections or other inflammations. And as it was said in the previous lecture, in case if we suppose affection of central nervous system, the most convenient way to identify this, to reveal this, is to conduct lumbar functions, and if we observe blood in silent liquor, this proves the diagnosis of CNS infection. Clinical remission is stated when the blood neutrophil count is more than 1.5 thousand per liter, and appropriate closer, not normal, but close to normal platelet count as well. In circulation in peripheral blood, there should be no blasts, so no blasts absent. Then the bone marrow cellularity should represent not more than 20% of the blast, as it was said before, and but better if even 5%, blast. And extramedullary leukemia should not be present. There should not be accumulation of metastasis in extramedullary foci. Prognostic factors, as we discussed with you previously in our previous lecture, age matters. Remember, I'm going to make it now, just a few seconds. Then, if there are antecedent background chronic or acute diseases, they may worsen the condition. They could be tolerance to therapy. They could be chromosome changes which worsen the prognosis. Molecular markers also help us to predict the course of this disease. And it depends also on the course of the disease itself. I will not focus, I will not discuss the peculiarities of treatment, and we stop now, make a pause for 10 minutes for the break, and then continue with acute lymphoid leukemia. 10 minutes for